Okay, good morning, everybody. Thank you for joining us. As I say, every week we'll start with just giving it a second to let everybody join in the Zoom webinar. Thank you again for being with us today. We have a really great presenter that will be coming on in just a few minutes. Before that, we have our usual weekly updates, and we'll start with Dr. Will Collins to talk about the inpatient census and updates. Thanks, Will, for joining.
Sure. All right, can everybody see? All right, I got thumbs up. So I'm gonna briefly talk just quick context of where we're at nationally and locally, and then show our inpatient numbers again. If it will go, there we go. So I think as we all know, cases, hospitalizations, and now deaths, unfortunately, are rising across the country at a pretty substantial rate. So showing the curves here from the New York Times and the COVID tracking project. You can see in the red, the cases, the blue hospitalizations, and the gray is deaths. Just to put some more hard numbers on it, we actually had 1 million new cases in just 7 days at the beginning of November, from the 6th to the 13th in the country. And California itself is now over 1 million cases. Looking locally, we've been showing these curves most weeks, and looking here at the trend in the last few weeks, and you can see in particular Santa Clara County in the purple, hospitalizations is up quite a bit. And a number of governors across the country recently put in more significant restrictions, including in California, where Gavin Newsom announced an emergency break. Hey, things. Sorry, my son decided to fill his cup with ice right in the middle of this. As you can see here, we had an emergency break on November 16th. And so almost every county in the Bay Area went back to purple, except for Marin, San Francisco, and San Mateo, which are now red. For the Stanford numbers, we are seeing some increases in number of positive cases per week, as well as hospitalizations now in the last couple of weeks. If you kind of look at the trends here, not necessarily significant, but starting to see a clear upward trend. This is our census day over day, and there is a little tail here coming up. As of last night, there were 15 patients with COVID in the hospital, 14 on the floor, 1 in the ED, and there were actually none in the ICU, which is a mild amount of good news. Again, showing our demographics from March 1st to November 15th, basically the same in terms of our percentages, a little over 20% needing ICU. Our death rate is about the same. Our age range, female to male, and race and ethnicity breakdown are similar as before as well. So thanks again to everyone who helps with these numbers. I think Brian's next, so I'm going to stop sharing.
Awesome. Thank you, Dr. Collins, for that update, and appreciate your keeping us updated every week. Before we present our new presenter today, just wanted to briefly mention this upcoming next week, we have no medicine grand rounds as Thanksgiving is coming. And then the week after that, we have Dr. Ed Damros. We'll be talking about his experiences in Guam earlier this year during the pandemic. And the week after that, speaking of travel, for those of you who may be traveling, hopefully not, Dr. Lin Chen, who's the president of the International Society of Travel Medicine, will be talking about travel and talking about it in a population level. So we're looking forward to that as well. So our presenter today is Dr. Richard J. Barron. Dr. Barron is the president and chief executive officer of the American Board of Internal Medicine and an ABIM Foundation. He's a former chair of the American Board of Internal Medicine's board of directors, and he's certified in internal medicine and geriatric medicine. By 2001, he'd already spent 30 plus years working as a clinical internist, both at a busy city in Philadelphia, greenhouse internist, as well as having many years working in various areas such as rural locations as well. From 2011 to 2013, he served as the group director of seamless care models for the Centers of Medicare and Medicaid. He served on the board of National Quality Forum and their Health Information Technology Advisory Committee. He's had many years of experience in multiple areas in delivering healthcare. To save time, I didn't go through all of it, but I just would like to say we're really thankful to have him with us today. As the president of the ABIM, he's going to be presenting on a very important topic. And Dr. Barron, I will have you go ahead and get your slides going. He's going to be talking about mistrust in healthcare as a social determinant, a topic very important, perhaps more important now than ever. So we're looking forward to hearing about that. Dr. Barron, thank you so much for being with us today. I'll turn it over to you.
Thank you very much, Earl. I appreciate it. Thanks to Dr. Harrington for the invitation. Thanks especially to Abraham Verghese, with whom I got to serve on the American Board of Internal Medicine. Both of us were directors together. And we kind of almost overlapped in East Tennessee. When I finished my training at Bellevue, I went with the National Health Service Corps to rural Tennessee, where I was the only physician in the western half of the county. I was about 3 hours south of where Abraham was, where the area about which he wrote My Own Country, a very beautiful book, and 3 hours south and 3 hours before, 3 years before. And at Bellevue, we think that the index case of HIV was at Bellevue. And I left Bellevue thinking, how could we be focusing on diseases that 23 people in the world have had, each of whom has had in excess of 1,000 sexual partners. And I go to rural Tennessee and I wind up taking care of a young man with lymphadenopathy and fever, the only case of secondary syphilis I ever saw, the only Herxheimer reaction I ever saw. And he was the first case of HIV in Tennessee. So sometimes things you think you don't need to know, well, maybe actually you do. And I left just as Abraham arrived, and I was at the beginning of the wave. He was there at the crest. So once again, even though I had my sharing going, hold on here, folks, and we'll see if there we go. So we do have a disclosure of ABIM service. The important thing on this slide is I'm not going to share any exam questions, so don't look out for that. And I do want to start with a story from early in my career when I was a very compulsive doctor and I was still doing a full review of systems and every part of the physical exam that I'd learned, and I was just totally comprehensive. And I saw as a new patient an African-American sign painter. He was in his early 50s. And I did my usual, I did everything. I did soup to nuts. I was really comprehensive. And at the end of it, he looked at me as he's getting dressed and he said, Dr. Barron, I want to ask you something. If I were a US Senator, would you have done anything different than what you just did? And the question really surprised me because there I was being comprehensive, being my best self as a doctor. And this guy's asking, like, did you do less for me than you would have? And I was trying to figure out what's that about. And I realized that he had had a whole bunch of experiences over the course of his life where he did not get the same treatment that other people got. And he wanted to know if I was one more in that long line of people giving him something different. And of course, I assumed, well, no, I wouldn't be doing that. But it really was educational to me to think that he looked at it a little bit differently. So what are we going to talk about today? He's a kind of reference narrative. We're going to talk about licensing professional self-regulation. We're going to talk about a broad secular loss of trust in facts and expertise. We're going to talk about medical mistrust and the way it relates to structural racism and why facts alone are not going to be enough of a strategy to turn the tide. I think all of us in medicine really pride ourselves that we are science-based doctors, and we think that the way we succeed with our patients is because of the quality of our science. Certainly we need that to take care of them, but I don't think that's going to get us out of the predicament that we're in. So as you know, I'm the CEO at the American Board of Internal Medicine, and you could say that we're in the certificate business, that we're out there selling certificates, and that's actually a much more competitive business than you might think. Here's a certificate that was displayed in the fruit and vegetable cellar that I purchased vegetables at here in Philadelphia. And the guy had sent $10 off to a place on the web that had sent him this beautiful certificate suitable for framing that he's a master of mangoes. Well, this is one kind of certificate, and okay, it's a joke, like you can't do anything with this, so what? It doesn't mean anything. But these days, there are actually certificates you can get on the web that allow you to do other things. Like you can become an ordained minister on the web in an hour or so. And that gives you the authority, as it says here, to perform weddings. And maybe you care about that, maybe you don't. My son was actually married by a web designer who spent an hour on the web getting this ordained as a minister and had legal authority to marry my son in the state of New York. And that was fine with me. I didn't care that much. But that's my wife with him. They're walking down the aisle together. You all don't know her, and you don't know that she's actually wearing a wig because she's in the middle of treatment for a very aggressive form of breast cancer. And though I didn't honestly care about the credentials of the person who married my son, I cared a lot about the credentials of the person who took care of my wife's cancer. There I really was looking for something different. And so are most members of the public when they're out there looking for a doctor. So this is a quote from Paul Starr's book, and it's gotten somewhat out of vogue, but it was sort of a Bible that all of us read in the era that I trained. And he poses the question for himself. The book is called The Social Transformation of American Medicine. And he's asking, how did doctors get from the economically marginal position of the 18th century to the economically dominant position that we were in the 1980s? And he actually talks about Benjamin Rush, a Philadelphia physician, signer of the Declaration of Independence, who counseled his colleagues in Philadelphia that they should plant a garden. Why should they plant a garden? Lest they go hungry and then have the improvident wish for a plague to strike the community, which would generate fees. And he uses that as an example of the marginal basis, the marginal status of physicians in the late 18th century, which was completely unrecognizable when he wrote this in the 1980s. But he points out that it's not about individually received wisdom, private idiosyncratic standards, but a community of shared standards. Well, you all know that the American Board of Internal Medicine went through some pretty turbulent times, and still, many ways, still kind of turbulent. And after our chair wrote an editorial in JAMA about what we do, he got this correspondence from a diplomate in Texas. And this is different. This is not somebody talking about being a proud representative of a community of shared standards. This is somebody who says, I am a competent doctor, and I am not ceding authority for my competence, self-determination to you or anybody else. And reframing the issue from an issue of a community of shared standards that validates expertise to self-declared, I am who I am, and you should rely on that. So how did we get from Paul Starr's community of shared standards to this correspondence from a diplomate? Well, a quick crash course on becoming a physician community. Let's start in the 1700s. And the first medical society of, quote, these United States, unquote, because it's 1777 in Litchfield, Connecticut, they form a medical society. And one of the core responsibilities that they take upon themselves is they are going to examine for ability to practice anyone who presents himself to practice in that community, because they're doctors and they know who real doctors are, and the public necessarily might not know that. Well, at the founding of the Republic, all but 2 states require a medical license. That's not actually 1830. I'm sorry, at the founding of the Republic in 1787, only 2 states require medical licensing because it's a free country. Anybody could be a doctor. Why does somebody get to monopolize or limit that? But by 1830, all but 2 states are requiring medical licensing. And you think that's linear progress, we're moving forward. We now have an expectation for licensure. But in 1828, Andrew Jackson gets elected on a very populist agenda that says, you know, all this expertise, all this facts, all these, that it's just elites trying to exploit the common people and extort things from them. And this is a bad idea to centralize power that way. And in addition, in the 1820s, the medical profession had a food fight with itself. Who are the real doctors? Is it the osteopaths? Is it the allopaths? Is it the naturopaths? Is it the Thompsonians? By 1857, only 2 states require a medical license. The state legislature said, if you guys can't agree on who it is, and we're in a climate where doctors are just there to centralize power and exploit common people, why should we get involved in regulating this? And folks, this may seem like ancient history, but if you hear ads for hymns on TV, it's like, you don't need a doctor to get your ED meds. You don't need a doctor to get your hair loss meds. You can just go to our website, you'll get a confidential medical evaluation, maybe, and you'll get what it is that you need. And that is emblematic of a trend of people saying, I don't know whether this expertise is in my interest or in their interest. I don't know whether the doctors are doing this for me or for themselves. Well, another part of ABIM's story is a story about recognizing specialization. And in 1865, the New York, and this is the first meeting of the AMA after the Civil War, and the AMA at this time is only 30 years old. The New York delegation comes to the AMA with a special complaint that would be of interest to Dr. Harrington. There are doctors in New York who are advertising that they have special expertise in heart disease. And says the AMA, they don't actually have special expertise in heart disease. They just say they do. And in the words of the complaint from the New York delegation, it's a naked attempt to grab patients. And the New York delegation, the relief that they wanted was specialization should be declared unprofessional. Anybody who said they were a specialist should be kicked out of the AMA. The AMA appointed a committee. They didn't have Zoom and they didn't have the internet. And so it took them 3 years to come back with their report. Their report was, actually, it's not specialization that's the problem. Concentration of knowledge could be a good thing. It could advance science, could advance research. There could be individuals who have particular qualifications for helping patients. But we shouldn't have self-declared expertise. Expertise should be validated by a third party. Well, you're reading the same headlines I am, and you're reading them perhaps with more interest than I am. What's the difference between Dr. Scott Atlas and Dr. Tony Fauci? Who has verified expertise to manage a pandemic and advise the president of the United States, and who just says he does? And what kind of world is it when people who just say they have that kind of expertise all of a sudden start to be able to move in that way? Our profession has always tried to carve out our own role in determining who our experts are. So in 1916, the first board is created. That's the American Board of Ophthalmology. 1936, the American Board of Internal Medicine. So just sort of a quick run through of ways that medical organizations come together. Professional societies wind up creating standard setting bodies. We were created in 1836 by joint action of the American College of Physicians and the AMA to create a board to independently verify expertise in internal medicine. Well, a lot of people say, do you really need to do this? And of course, one of the most contentious things we've done has been the maintenance of certification program, where we expect continued demonstration of ability over the course of career. And if I'm going to give you one slide that provides the sort of theoretical framework and empirical evidence for why this is important to do, it's the slide of the Dunning-Kruger effect. And I don't know how many of you have heard of the Dunning-Kruger effect, but this is the graph that David Dunning published 30 years ago. He's a professor of psychology, and what he did in his undergraduate course in psychology 30 years ago was he had his students and he asked them, before he gave them an exam, to rate how well they thought they had learned the material in the course. And he had them do that, and then he gave them an exam. And then he compared how well they thought they did with how they actually performed on the exam. And what he found was, for the top 2 quartiles, and maybe even a little bit the 3rd quartile, people were reasonably good judges of their ability. But when you got to the bottom, the gap between what people thought they could do and what they actually could do, what they knew and what they didn't know, became pretty big. And it's got a fancy name and it's got a graph and everything, but you all know this, that it's the people who know the least, who are most confident in their ability to move forward. And if, as a profession, we're going to take responsibility for putting ourselves out there to care for the public, allowing people to self-declare, hey, I got this, when they're in this group, it's fundamentally not safe. Now, another thing that gets repeated a fair amount is there's no evidence that board certification makes a difference. As you heard in my introduction, the job I had before I had this job was at the Innovation Center at CMS, leading the Seamless Care Models Group. And there, what we were focused on was trying to improve quality and decrease cost. And so I was pretty tuned into that when I started at ABIM, and we had just completed some research where we looked at the 88, 89 cohort of doctors who didn't need to do MOC, and looked at the 91, 92 cohort of doctors who had time-limited certificates. And we went to the Medicare claims database. We did a clustered control trial comparing the practices. And what we found, and these days we present some of our data with infographics because that's how people pay attention, was that they were spending 2.5% less providing care to those patients, the people in the MOC group, than the non-MOC group. And that difference in cost did not come from decreased readmissions or decreased emergency room visits, both of which would be structural measures of health system performance. They actually came from decreased testing and decreased consultation. Those folks spent less money because they knew more. Looking at the Medicare claims database, we didn't find evidence of difference in quality, but Medicare claims database is not where I go to look for differences in quality. And again, on our website, we have a bunch of literature that describes increased adherence to preventive care guidelines, better care of diabetes, a whole variety of things in people in the MOC program relative to not in the MOC program. So what's changed? Why are we all of a sudden in this controversy where we are getting the individuals saying it's about me and I'm not going to cede my authority? Well, facts have always been politicized, and here are 3 books that I'd encourage, or 3 resources I'd encourage any of you to take a look at. The first is The Fruits of Philosophy on the far left, and this was a book published in the US by an American physician in 1831. And his interest was in helping people have the knowledge they needed to control their size of their families. And it's a very tactful book, The Private Companion of Adult People. It's a book that explains female reproductive anatomy and attempts to explain how contraception actually happens, with the goal of informing patients how to practice contraception. Now, there are a few things that are pretty fuzzy. It's a fun book. You can get it on Google Books. Like, for instance, they're not really sure how the sperm and the egg actually meet up. In fact, they're not really sure that the sperm and the egg do meet up. There are still people who subscribe to the homunculus theory that it's all in the sperm. But no, it could be that the sperm and the egg meet up, and but they can't imagine that the sperm could get through the cervix and into the fluid. There must be some channels in the vagina we don't know. Anyway, this was a book designed to empower people to control their families. This book was declared illegal in England, and people were sued for publishing it. And the medical society, the Royal College of Physicians, took the position that doctors who provided this kind of information to their patients were being unprofessional. So we've got the politicization of reproductive health and contraception, which is certainly with us today. The next one I think is very relevant to where we are. It's the Segrist lecture of the American Association for the History of Medicine. It's given, and it is given by, oh my goodness, now I am blocking his name, but it'll come to me in just a second, Erwin Akkernecht. And he is writing in the late 40s, early 50s, and he's saying, well, we have this germ theory. And the germ theory is truth. We know, since Robert Koch proved that the tubercle bacillus caused tuberculosis, we know that the germ theory is there. And but he says, as a historian, let me look at a time when we didn't know that germs caused disease, but doctors actually had views on this. And he goes to the Paris school in the 1820s and 30s, where it turned out that doctors were passionately divided on whether germs cause disease, some particles cause disease, or whether miasmas cause disease. And as he says, in the 20s and 30s, 1820s, 1830s, they didn't have evidence to answer this question the way that Koch came with later. That didn't stop them from having strong views about this. And what he observes is that what separated the people in their beliefs was actually their politics. that the people who believed in the germ theory believed that rich and poor should be separated. And they believed and they didn't care that much about the environment. Whereas the people who believed in miasmas were the people who cared about housing and sewage and public health measures. And so this idea that doctors actually believed in the germ theory or not based on their politics, and I'm going to touch on this again later, look at what's happening with COVID, we know that this is not anything to do, we know that this is not anything, it is both the virus that's doing it, but the miasmas too. And then Rockefeller Medicine Men, this is a fun one. This is a guy who writes a Marxist critique of the Rockefeller Institute, which of course is foundational to our understanding of viruses and bacteria. And his argument is what Rockefeller did was he funded the Rockefeller Institute as a capitalist to basically argue for the proposition, it's not my fault. It's not my oil fields, it's not the environment, it's not all the things I may be doing as a capitalist industrialist, it's these viruses. They're the things that do it. It's a really interesting and fun read, and will sort of change your view of the birth of a scientific institution. But there are broader things going on in the culture right now. Rand has characterized them as truth decay, and they identify 4 key elements in truth decay. And these will be completely familiar to you. Increasing disagreement about facts and interpretations of facts and data. We're in the midst of arguing about who won the election, at least some of us are. So we have disagreement about facts at the highest level. We also have a blurring of the line between opinion and fact. It's harder and harder as you read the newspaper, even when you're reading, mainstream top-tier media, the New York Times, the Washington Post. Opinion and fact are being presented in ways that look very similar, and we no longer have the sort of geographic separation of an actual newspaper. We got a lot of information coming at us, and people may trust their Facebook feed more than they trust mainstream media. And then there's declining trust in formerly respected sources of facts. And I got to tell you, folks, this was a very salient experience at the American Board of Internal Medicine. I mean, when I took the job, it's unbelievable to me, 7.5 years ago, ABIM was widely respected. And then over the next 2 to 3 years, the reputation went into the toilet, and lots of people came to distrust us. And it was like, wait, what happened? How did that happen? I mean, we were a respected source of facts. And folks, I think those of us in clinical practice doing patient care, we are in the group of people who are increasingly being distrusted. Social media is clearly part of this, amplifies it, and it isn't bots, it's people. There's a lot more engagement in the kind of outrageous stuff that is out there. But the collective impact of all of this is to see confidence in institutions declining. And this is Gallup polls over the last many years. How much confidence do you have in institutions? And what you'll see is that the medical system over here had the most confidence in it, but we are the biggest loser. We went in 1975, 80% of people said they had confidence in the medical system. Today, that's 43%, a 54% decrease. The good news is we are still ahead of Congress, and we're still ahead of big business and the criminal justice system. But we're well below the military, and we're actually below the police, at least in the Gallup data. So there's really something happening at scale. It's not just us individually, it's our whole institutions and the institutions in which we practice. And we need to think about a systematic and organized response to that. There are a lot of intrinsic vulnerabilities in healthcare science. We keep changing our mind. How often do those mammograms? What age do we start doing colonoscopy? And of course, the science we have is not always individually applicable. We look at a research study that says people are more likely to do better with treatment A than treatment B, but that doesn't mean every individual will. Anybody doing clinical medicine is bedeviled by the uncertainty of what we do. And I'm going to come back to this point about scientists trained to disregard context, because I think that's one of the biggest flaws that we're facing right now. We think we're supposed to be focused on the science independent of the context. If we make the context disappear, we are lost with respect to being able to connect to patients in the current environment. And then we have other things, the impact of conflict of interest, both in research and in practice, issues about regulatory capture, our poor management of quality and safety. I'll never forget rounding in the nursing home when the National Academy of Medicine IOM report came out to err as human, talking about 100,000 deaths, and every patient I was seeing in the hospital and every patient I was seeing in the nursing home is wondering, am I about to be one of them? And our inability to persuade patients that we can manage care safely, this is an issue. Limitations of acute healthcare and social determinants, I'm going to talk some more about that in just a minute. Disparities are glaring evidence that our science isn't getting us what we had hoped and what we are promising with it. And aspiration will, of course, always exceed reality. So what are some of the origins of that mistrust? And equally importantly, what can we do about that? Well, now I'm going to spend some time talking about the health equity and disparities issue. And these are some historical things. I don't know how many of you know, on the right, that's Marion Sims. He is described as the father of modern gynecology. Internal medicine colleagues don't spend a lot of time thinking about Sims. Abraham actually is pretty knowledgeable because his original surgery, the great thing he did was he came up with a way to repair vesicovaginal fistulas that were a consequence of delayed childbirth or prolonged labor where that tissue dies. And this was, of course, a very debilitating injury. And he was the first surgeon to actually design a surgical approach. And he is lauded for this. But what people don't tell you is that he was a South Carolina slave owner, that the original patients that he practiced his surgical techniques on were women that he owned, that he did this surgery without anesthesia. And this is the kind of thing that our African-American patients are more aware of than we are. Most of us are aware of Tuskegee. I don't know how many of us are aware of the eugenics movement and the way that that was designed to keep immigrants out of this country. An extraordinary book called The Guarded Gate describes the way in which mainstream science eugenicists got together to do a bunch of totally bogus science that was fundamentally racist. This is historical stuff. But we have real current stuff. We have the Black maternal mortality rate, which is a shame for it is vastly ahead of the white maternal mortality rate, and COVID-19 and all the disparities associated with COVID-19. And this is really about structural racism. And as an individual, when talking about me with my patient, the sign painter, it's like, I didn't do anything wrong to you. Why would you suspect me? This is data from David Williams in a talk he gave to our group. How long did people wait to vote in 2012? The answer is it depends on your race. And as David points out, this isn't because the poll watchers or the people in the poll don't like Black people or don't like Latinx people. This is a bunch of decisions that got made prior to Election Day, prior to with everybody lining up. Resources, how many polling places are there going to be? How many of them are going to be open? We all saw what happened in Milwaukee during the primaries in Wisconsin. So one of the things to understand about structural racism is it's not about what an individual did today. It's about the whole way that society comes together to predetermine this stuff. And then, of course, deaths due to COVID-19, and these are national data updated from last week. And you can't use the germ theory, as much as we understand COVID as a virus, as much as we understand, as much as the vaccine is going to depend on successful explication of viral science, this isn't about the virus. This is about the miasmas. This is about the way in which the lives people have, the housing they have, the jobs they have, how they get to work, what their home situations are. These are the things that differentiate. And thinking this for people who are in the disfavored categories here, this is evidence in an ongoing way that they should not trust the health system, because the health system is doing twice as bad a job taking care of Black people as it is white people. Misinformation breeds mistrust. There's a lot of anti-science rhetoric coming from the top. And again, this has become increasingly salient as we look at the way anti-expertise rhetoric and books like The Death of Expertise describing this more broadly. We have the anti-vaccine stuff, and I think you all are likely familiar with the statistics that say that from Pew that say that the willingness to take a vaccine has declined 20% between March and April and now, and also that looking at the Black community, we're looking at about 40% who say they would take a vaccine. If those are the populations at risk and we can't figure out how to build trust in those populations, we are in big trouble. And then there's this pain myth. There are medical students who still believe that Black patients feel less pain than white patients, that they've got thicker skin, that they don't feel pain. And this mistrust, it's not merely the opposite of trust or the absence of trust. It's not just interpersonal trust. It's not just me and my sign painter. It's mistrust in institutions and systems. And most importantly, it's a protective response that it's warranted. It's not just historical. It's what's happening right now. And that engenders this mistrust, which we have to, as a healthcare system, think about ways to address. And for a lot of outcomes that we care about, mistrust is associated with worse outcomes in a variety of ways. And all of this is familiar to you. So what are some pathways to trust? Well, speaking against your own self-interest when you say things that are unexpected, I think we underutilize information technology to help us know and connect to patients. The famous social history that residents and interns often reduce to, do they smoke or do they drink? And I will say when I'm precepting, no, if it's the social history, it's what brand of whiskey do they like to drink and where do they like to drink it? The social history is a way that we can record and connect things that our patients care about. Saying things about your colleagues, positive patient handoffs, building relationships, most importantly, connecting facts to patients' particular predicament. And I'm going to come back to that because I think that is, at the individual level, the most important thing we can do. We at ABIM and the ABIM Foundation have launched a grant program just last week in collaboration with the Alliance for Academic Internal Medicine, our colleagues at ACP and the Josiah Macy Foundation, to fund grants, innovations in medical education and training designed to advance health equity and trust. The letter of intent deadline is December 10th. The word has gone out from AIM, it's gone out from us, it's on our website, and there will be small and large grants that we're doing together. We think it's critical that we start trying to discover ways to rebuild trust, and we think that you and your community as an educational community are an important place to go for ideas on how to do that. You know, we have a certain amount of arrogance as physicians. Doctor saying to the patient, don't confuse your Google search with all my medical training. Patient, don't confuse the 1-hour lecture you had with my 20 years of living with it. So I think the core problem here is something that a physician writer, Walker Percy, helped address in an essay called The Message in the Bottle, where he talked about the way that scientists can be removed from the predicaments of real people. And he describes the scientist as being someone who doesn't have a predicament. They're in this objective world. They're disregarding context, and they're looking for knowledge that they might want to arrive anytime, anywhere. And it's disconnected from reality. But Percy observes that real people have predicaments. They're in a problem, they're in a situation, they have a predicament, and their knowledge is relevant to them. The value of the knowledge has to do with its relevance to their predicament. For scientists, it's, is it reproducible? Is it reliable? Is it true in some cosmic way? And that is very important knowledge to have. But the idea that the connection between that knowledge and what patients need, patients' particular situations, that's where we need to be. So we come into the room with all kinds of expert knowledge, and patients come into the room with all kinds of expert knowledge too about their own lives, about their situations, about their priorities, about what they are looking for. Our goal when we're in the room with them is to try to put that together, to try to make it so that our expertise and their need work together. And we can do that. We really can do that, but it requires thinking intentionally, not just about the science and the right treatment, but how to connect that knowledge to patients' individual predicaments. And, you know, I started with the wedding story. That's my wife and I, after her successful treatment for breast cancer on the Inca Trail at Machu Picchu. And so that story has a happy ending thanks to skill and expertise of a number of terrific doctors. But one of the things they did was they deviated from the chemotherapy protocol to let her be able to go to the wedding, because they said, we don't know if you're going to be here next year, so don't miss your son's wedding. Well, she was here next year. She's here now. And the ability to take that expertise, put it in the service of an individual, and be aware of that person's context, that's core to what we do as clinicians. So thank you for your time. I did want to leave time for questions and interactions, and I wanted to share an email address and a Twitter handle because in a perfect world, I would have been there with all of you and be able to talk to you face to face or have lunch or have had breakfast, but we don't have that. So really, truly feel free to reach out by email if there are any of these ideas you want to engage with. And let me turn it back to Errol and Bob to moderate from here.
Dr. Barron, thank you so much for that. We'll send out in a follow-up email your contact information as well, so people have it to reach out to you. Thank you for sharing that. Thank you for sharing the story, follow-up. I was wondering how the story was going with your wife. Thank you for sharing that as well. It's great to hear, and send the best regards to myself and our whole community. I want to get into questions as they pop up and try to get through as many as possible before we get to 9 o'clock. Dr. Stephen Ash, who's a Vice Chief of our Division of Primary Care Population Health, asks, Stanford recently distanced itself from some of the presidential advisor Scott Atlas's comments on COVID. What is the proper stance on academic medicine in situations like this to foster trust? This has been a big one for us, as you can imagine. And
oh boy,
just the last couple of days.
No, it sure has, and I think it is what I saw the Twitter thread yesterday of the institution saying he doesn't represent us and our views. That's different from saying the views that he represents are incorrect, unfounded, and unscientific. And I think the institution can say that and needs to say that because they are. And you know, we get criticized a lot for having single best answer questions, like, oh my God, that's such a retro, medicine isn't like that. One of my hypotheticals is if our infectious disease board had a multiple choice question and one of the answers for how to manage acute COVID, and one of the answers was hydroxychloroquine, is that the wrong answer? And it is the wrong answer, and we'll say it's the wrong answer, but the president of the United States thinks it's the right answer. And Scott Atlas thinks herd immunity is the right answer. He's just wrong. And as an expert community, I think we need to call that out as a community, that this does not meet our community standards. He's speaking for himself, not based on any scientific expertise.
I think that's well said. Thank you. Moving on to the next question, Dr. Rishi Raj, one of our excellent pulmonary medicine doctors, he states, thank you for the excellent talk, Dr. Barron. I had a question regarding recertification. If one were to follow the stated rationale for recertification, one comes to the logical conclusion that MDs who are farthest away from graduation or training need it the most. And yet the rules exempts this very group from recertification. How does ABIM rationalize this decision? And he mentions, I've heard some physicians joke about this. They picked up the cutoff year based on the youngest members of the panel committee making the decision who graduated. So as a side joke, but what are your thoughts on this?
You know, I think the thing that ABIM got the wrongest was not having made a clear case for why we needed to have time-limited certification, and not only not making that case clearly at the beginning, but spiking our own tires by recognizing grandfathers, which became a kind of ticking time bomb of people saying, wait a minute, you're making me do this, and you're not making the people who most need to do this do it. I think that the way that the board looked at that at the time was it was the political deal they thought they needed to do to get it done. By the time I got into leadership here, it was a group of people who viewed this as a kind of birthright. I think the best solution we're going to have to that is some version of transparency, of being clear with people about when was the last time we validated somebody's expertise. The way the board looked at it, quite honestly, was it was a promise we made to doctors who took their exam before 1990 that they got a certificate, and we didn't make it conditional, and we didn't feel we could break that promise. Increasingly, though, I think there's a lot of discomfort with that, and that's a terrific question, and I am not proud of the way that the board's community generally is handling that. But transparency, we do put the original certification date on our reporting website and the status of current certification. But it's a fair question.
Great, thank you very much. Dr. Youssef, saying also a primary care doctor here at Stanford, asked, thank you for your presentation. I wonder what you think about the effect of money from pharmaceuticals in healthcare research and the level of trust in healthcare. Also, currently, healthcare is currently an industry. How do we move it to become a human right away from profit?
Right. So I'm not a fan of pharma. In my years in community practice, I never let drug reps in, and I started practicing in the 80s. So that was a pretty deviant thing to do. But I also acknowledge that, you know, if you gave me $2 billion, I couldn't give you a COVID-19 vaccine. So I think we have to acknowledge that pharma plays an important role in the culture, in the society, and in generating and bringing things forward. I think it was interesting that it was pharma leaders who got together saying, we're not going to release a vaccine until we meet FDA standards, and we're not going to let the president tell us when to put the vaccine out. And it was a moment when actually it was pharma leadership that was trying to restore trust in their industry by reassuring the public that they were going to do something that the government, which used to be responsible for that, wasn't willing to do. It's interesting because, of course, the FDA is supposed to be looking over pharma's shoulder, and the idea that that pharma needed to say, no, we're going to do this ourselves because we don't want to release an unsafe vaccine. So I think they do need to take trust very seriously. I think as an industry, they're aware of that, but it's not always the way they behave, and certainly not the way they behave in terms of their pricing and some of their transparency stuff. But I think if you look at the way they've managed some of the COVID stuff with the vaccine development stuff, their level of transparency, their level of public commitment has been remarkable, and we needed them to do this, and we're grateful that they did. I'm surprised to see myself saying anything positive about them, but I do think they need to focus on rebuilding trust and demonstrating that their products are safe and beneficial.
Great, thank you. Jeff asks, excellent talk. Thank you for your presentation. Thank you for your professionalism. Some criticism of MOC was that it did not represent fairly what most physicians actually do in medicine. Do you have any comments on this belief?
Yeah, great question. And I think I'll answer it on multiple levels. The first level is I think that to the extent that we're discipline-based and people evolve that discipline and focus within it, you know, at the end of a gastroenterology fellowship, a gastroenterologist is a kind of pluripotent stem cell that can go in a bunch of different directions in gastroenterology. And it's fair that the ones who, you know, what they do is inflammatory bowel disease, and they're not doing esophagus, or they're not doing the colon or whatever, they say, you're testing me on things I don't do. And I think there's some truth to that. And we have moved a lot to try to get closer to what people are actually doing by having the blueprints that structure the exams be reviewed by practicing doctors in the field. That's one step. And we're also trying to develop programs that would allow gastroenterologists to sort themselves and other specialists as well, so that what they're tested on is closer to what their practice is. So I think there's some fair criticism to that, and we're moving in that direction. But I also, you can't resist telling the story of that I heard from Northern California of a patient who had to travel 2 hours to the VA for his pacemaker check, who was in heart failure. And the electrophysiologist, when he presented his heart failure symptoms, said, I'm the wrong cardiologist, I'm the wrong heart doctor, I'm the electrical cardiologist, you need to see the heart failure cardiologist, and he's not available today. Like, we don't want a world that looks like that either. A certain amount of breadth of knowledge in the field. And also, as in my HIV experience in Tennessee, the stuff you don't think you're going to need, actually, sometimes you really do. And so I think I wouldn't diminish the value, especially as a primary care doctor, of breadth of expertise in the field.
Great, thank you very much. I have a question here from Dr. Kenneth Weinberg, joining us from the Department of Pediatrics. So thank you for joining us here. He asks, how much has blurring of medical beneficence and monetary profit, for example, the Bay Act of 1980, led to researchers seeking corporate profit from their federally funded work? Has that contaminated the field?
Yeah, I don't think I have enough expertise to answer that question in detail. I think that again, it's a complicated world. When I first came to Philadelphia, I was on the faculty of the Medical College of Pennsylvania, which got purchased by the Allegheny Health System. The Allegheny Health System went on a spectacular acquisition spree and led to the largest nonprofit bankruptcy in the history of the United States, with $1 billion in liabilities and like $100 million in assets. They defaulted on their pension funds. They couldn't make, it was a big story in Philadelphia. They were a nonprofit. And the year that was happening, I was lecturing to the MCP medical students, and somebody asked, isn't for-profit the problem in healthcare? It's certainly part of the problem in healthcare, but being a not-for-profit does not solve all the problems. Every organization has to generate some margin to stay around, and you can't operate. In my entire career, the only for-profit I've ever worked for was Greenhouse Internist, the community practice that I founded a few blocks from where I'm speaking. Everybody else was either government or nonprofit, but my practice was a for-profit because that's the way medical practices are organized in this country.
Gotcha. Dr. Barron, we have a question from Dr. Erica Schillinger from our primary care population health, who's also in charge of section chief for education. She asks, thank you for the terrific talk, Dr. Barron. Do you have specific suggestions for integrating patients' perspectives into our practice and training of learners?
Oh boy, absolutely. I mean, I think I'll go back to those sort of stray comments about the social history, that you have to give people a framework for understanding that if they're not connecting to their patients as people, if they're not understanding who they are, I'd encourage everybody, the reading, I didn't do it full justice, but the Walker Percy essay, The Message in the Bottle, How Queer Man Is, How Queer Language Is, and What One Has to Do with the Other, is, I think, a very helpful thing for medical students. I think literature in medicine is another way to build empathy. And again, I know Abraham is all over that. I think people reading, there are a whole variety of well-worn literary gems. Some of my favorites, John Updike from the Journal of a Leper. I think it's about coming up with ways for medical students to understand their work in the human context in which it's happening.
Great. Thank you. I think I'll end on just one last question. It's an interesting question, and I'm going to loop in another question that's similar theme. There's an anonymous question to ask, and is trust higher in countries with a national healthcare system and more modest compensations, like in Canada? And And a question here from Jack Mormon, I want to pull up as well. Thank you for the excellent thought presentation. Has the ABIM taken a position on some form of universal healthcare in the US?
So I'll answer the second one first because it's easier. The American College of Physicians or the American College of Cardiology, these are membership organizations that are designed to distill and channel the voices of their members. And when they take a position, for better and for worse, it's informed by all of the people who feed into that. ABIM's not that kind of organization. If we take a position, it's the people who are ABIM, which is a smaller group and is not representative in that sense. We're not crowdsourcing the truth at ABIM, where we're not asking people to vote on whether hydroxychloroquine is or isn't the right drug. We're really looking at the evidence for that. So we don't reliably take political positions. We have been active in things like the J-1 visa program and commenting on that because so many internists and internists in training were affected by it. So we did get involved in that. With respect to National Health Service, again, I think trust, some places they trust the government, some places they don't. Some places they trust the hospitals, some places they don't. I think becoming trustworthy is a challenge for every health practitioner, every health system, every player in the entity, in the enterprise that is healthcare. I'm not reliably convinced that government healthcare has more trust than non-government healthcare. It probably becomes more dependent on how much trust people have actually in the government.
Thank you very much. Dr. Barron, thank you so much. The number of questions, I hate to leave questions on the table. I will send, if you'd like to answer them, I'll send them over to you
Great.
after, and we send an email out with this recording so we can send those questions out. People can see your answers still. So I apologize to those of you who questions we didn't get to. There's also a lot of great comments saying thank you for the presentation, and everybody's very appreciative of that. And I'd like to also share my thanks as well for you taking the time to join us today and share your thoughts from you and the ABIM. So thank you again. Thank you to everybody for joining us or watching, and of course our panelists as well for being with us today. And I hope everybody has a great week, and thanks again.
Thank you all. Stay safe. Thank you very much.
Thank you.
Bye-bye.